Yeah. All right, let's get started. Hello, everyone, and welcome back to Club Med, Call Through Fall. Today, we have Dr. Sierra, and she will be talking about her life as a pediatric clinical pharmacist. And you guys can ask any questions in the chat as we go along. So first, she'll start off with a little bit in her day in the life and what she goes through, and then she'll end it off with a case study with she'll also be talking about one of the most expensive drugs in the world, so make sure you guys stick around for that. Do you want to introduce yourself?
Sure, I'm going to go ahead and share my screen now so you guys can see it. All right, so like she said, my name is Dr. Sierra Richard. I am a pediatric and women's health clinical pharmacist. And I'm really excited to talk to you guys today about just my role as a clinical pharmacist, how I got to be a clinical pharmacist. And then, like she said, we're going to follow up with one of the coolest drugs on the market, in my opinion, which also happens to be the most expensive, but really a direction that we're going in and probably what some are calling the future of medicine. So you definitely want to stick around for that. So I wanted to start out by telling you kind of what my training looked like. So I did 2 years of undergraduate studies at Arkansas State University. During that time, I did my prerequisites. I knew that I wanted to go to UMKC School of Pharmacy, so I really focused in on those prerequisites and took those courses. Those are basically your biology, your organic chemistry, biochemistry, things like that that you need to take to, get to pharmacy school. Then I did 4 years of pharmacy school at UMKC School of Pharmacy. For my program in particular, we did 2 years in the classroom of didactic coursework. So this is all of our classes: medicinal chemistry, pathophysiology, top 200 drugs, things of that nature, and the basics of pharmacy to get to year 3, which is a mixed learning environment where you're part of the time in the classroom, part of the time at a specific site. So I did a hospital site and I was with hospital patients. I was counseling on anticoagulation therapy. And then in that last year, it's really just out of the classroom learning. You are at different sites. For me, I did everything from academia and administration to ambulatory care, where I was in a clinic helping manage diabetes for patients that were veterans. And then I did stuff like psych and neonatal intensive care units. So it really had a wide range of areas that I got to learn in. After my PharmD training was complete, I did a year of residency in Fort Worth, Texas at a children's hospital. So it was pediatric focused because I knew I liked to work with kids, and that is how I got to where I am. So it took me 7 years total to get done. I finished residency in July of this year. So I recently entered the workforce as a pharmacist, and now I want to kind of talk about a day in my life. So it's really more of a night in my life as a clinical pharmacist, since I'm an overnight clinical pharmacist. So currently I do 7 days on, 7 days off. I work from 9 p.m. to 8 a.m. Monday through Sunday, and then I get that subsequent Monday through Sunday off. So it's really nice and convenient having that flexible schedule. But my responsibilities can vary night to night. So my primary responsibility is verifying medication orders. So every single order that a doctor, NP, physician's assistant put in, I will review. Most of the time it's before the patient can get access to the medication. In the emergency department and the pediatric ICU, they can go ahead and override, the nurse can give. So I try to jump on those pretty quickly just to make sure everything's okay before the medication's given to a patient. I'm also answering drug information questions all the time. And the questions, when I pick up the phone, I never know what I'm going to get. So I'll get everything from questions about drug compatibility, can we run this IV with this IV, to questions that are really in depth. We have a patient with this disease state. What drug do you recommend? What dose do you recommend? So it can vary every time I get a call. I also, in my institution, monitor therapeutic drug levels. So antibiotics in particular is what I monitor mostly on overnights. So if we start a patient on certain antibiotics in order to make sure they're, one, not toxic, and two, actually at a high enough level they're effective, we have to watch the ranges that we're in. So I will actually monitor the drug level. I will put in my dosing recommendation, and where I'm at, the doctors don't have to do anything with that. They're just going to say, hey, we want this antibiotic. And then I do the dosing, I take care of it, watch their renal function, watch their liver function, and do dose adjustments appropriately. I also check sterile and non-sterile compounds. So anytime we compound anything, which we do a lot of compounding, especially for pediatrics, because we have to take tablets a lot of times and turn them into some sort of oral suspension so the kid can actually take it, especially our little babies, that they're not going to be swallowing a tablet. So we have to make something that they can actually take. So I check all of those the technician makes and monitor any other activities that they do. So our technicians are awesome, and they will be running meds up to the floor. Any order that I verify that's coming from the pharmacy, I will check before it goes out. Anything that goes in our medication dispensing cabinets, I look at. So I'm just monitoring that and helping them in any way I can throughout the night. I also complete clinical chart reviews for our women's health service patients. So basically, our women's health service does not have a pharmacist on day shift that is clinically reviewing them. So I've kind of taken that on nights, which is perfect because for some reason, a lot of moms decide they want to deliver in the middle of the night. And so I'm there first on and can kind of look and see what's going on. So what I do is I start by looking at their home medication list, make sure all of those medications are started inpatient and that they're all the right dose and we're on the right schedule and everything is matching home. I will also do a chart review of, making sure all of our indications have a drug if there's one that needs to be on there. So for example, one of the things I caught the other day was a patient was positive for trichomonas and we weren't treating it yet. So I recommended we start treatment because it somehow got missed that she had tested positive for that upon admission. Other things that I'm doing is just checking doses, making sure that there's no duplicate therapies if somebody accidentally ordered something twice, and just kind of being a double check for the physician team and making sure we're doing everything that we can the most effective way for the patient. And then the last thing I do is I serve as a member of the rapid response team. So anytime that there is a code blue called in the hospital, I will respond. I have extra medications that I bring. I typically will draw up any doses that need to be done, make dose recommendations. I time out doses. So you're supposed to give certain medications within a certain time frame. I'm timing those. When we had the last dose, is it time for another one of those? And kind of keep the medications on track, which is great because it frees up a nurse to do some of those other clinical duties that need to be done and taking care of the patient up close and personal. So for me, because of our hospital size, I'm actually the only pharmacist covering the hospital at night. So we have over 100 beds and I'm taking care of all of those patients at once. This includes our emergency department, our general pediatrics floor, PICU, NICU, and our women's health service. So got to cover it all. And that's why time management is my key to success. I have to know how to prioritize what orders are coming through and my phone calls. Really, that's usually ICUs and emergency department come first, and then other things coming through are second. I also know my medications pretty well, so I can know what's an emergency medication and what is okay to leave for later. Like Tylenol in most cases is not an emergency medication, but epinephrine is. So I'm going to be verifying that epi order before I'm verifying Tylenol. Also spacing out those chart reviews. I can have anywhere from 12 to 30 maternal health patients that I am looking at the night. So trying to space those out in between orders and in between busy times. Like I said before, really focusing on my sickest patients, who's in my ICUs, who's in my emergency department that's probably going to get admitted. And then just being flexible. We have certain times we like to do things, but that doesn't always happen based on what comes in. We may have an emergency situation. This patient's going to surgery and we need to make things for the surgery, the surgery right then. So, maybe this cart fill that we were going to do and bring medications up to the floor to the machine, that can wait until later. Some nights are slow, some nights are busy. Most nights fall somewhere in between that, where we have busy times and then a slower period. So just being flexible and being ready to do what I need to do in whatever time I have. So I did want to bring this up because I know that a lot of people on this call are interested in being maybe a physician. And so from a pharmacist side, I want you guys to know what my ultimate goal is as a pharmacist. And that's really to provide patients with safe and effective drug therapy with each dose. We are all on the same team. So when I am calling a physician because I'm concerned about a dose, it's not because I'm upset with them. It's not because they did something wrong. It's because I just want to make sure that what I am getting ready to dispense and send to the patient is going to be safe and effective for them. So I'm really here to back them up. I want to make sure that whatever we're entering is the best thing that we can give the patient at the time. So as a clinical pharmacist, there's a lot of things I love. I absolutely love my job. I was saying earlier that residency was the hardest year of my life, but it's been worth it for getting a job that I love, but it doesn't come without challenges. There are staffing constraints. So pharmacists are generally considered a cost saving versus a cost generating service. So what we often do is we look at medications and we take away medications frequently that are maybe not appropriate anymore. Most of the time they were appropriate when the patient was admitted, but now we're better, so we can take that off. So we're saving money there. We're also preventing errors, which are always costly to, one, the patient's health, and two, the hospital. And we also are looking at discharge medications and making sure we're making sure they're on the right medications when they go home so they don't come back. So we're saving the hospital money in those sense. So it's harder to justify staffing a pharmacist because we're cost savings versus we can't say we're going to make money, but we can say we're preventing a cost, and it's more hypothetical. There's also a lot of misunderstanding about the pharmacist role and where we fit in. Historically speaking, pharmacists have been in more of a dispensing role where we're just giving medications, whereas a pharmacist who's trained like I am through residency is really more trained for those medication recommendations, for doing therapeutic drug monitoring, for those clinical chart reviews. And a lot of people are still adjusting to that setup. And our healthcare system is as well. We're not typically reimbursed for those services. So it's a evolving role in really trying to get people on board that, hey, we're here to help. We're not here to judge whatever you put in. We're not here to change completely the way you practice. We just want to make sure we're doing the most safe and effective drug therapy. And a lot of that comes from the lack of knowledge of pharmacist education. So I didn't even know when I went to pharmacy school that pharmacists went to residency. Those were all things that I learned later. So teaching people, you know, a pharmacist isn't what they were before. Used to, it was a bachelor's degree and there wasn't the clinical training and there wasn't the residency afterwards. And now all pharmacists get a doctor of pharmacy degree. So it's very different than it used to be. And then the last thing is that the profession of pharmacy, aside from being concerns of oversaturation, there is still some gender and racial disparities that we have to deal with. So even though this is a profession where it is very female dominated. So I think the 2019 stats were like 62% of pharmacy students were women. We are still seeing a gender pay gap, which is very unfortunate for a women dominated field, and as well as disparities in leadership. And overall, just disparities in racial minorities being admitted into pharmacy school and being pharmacists. So those are all things that as a profession, we are working to change, especially I feel like my generation of pharmacists is very vocal about that and really wanting to see more openness to all genders and racial minorities so that it is just a field where everybody can feel represented by their pharmacist. So I know that was very quick. If there's been any questions about my training, I'd be happy to answer those now.
Yeah, there's actually quite a few. Just to go back a little, so what other specialties have you considered besides women's health and pediatrics, and why pharmacy?
Great questions. So I'll start with the why pharmacy question. When I was in high school, we didn't have BuzzFeed yet because I am a little bit older than you guys, but we had these quizzes that we had to take. It was basically essentially BuzzFeed quizzes where it was like, this is what you need to be when you grow up. And I got pharmacist and I didn't care. I was like a junior in high school. I was like, okay, whatever. My mom thought this was a great idea because she knew the local pharmacy needed somebody to do a summer job, and I didn't have one of those yet. So she told the pharmacist, and next day I had a job interview at the pharmacy. I ended up being a pharmacy tech that summer and absolutely fell in love with pharmacy. The reason being, I love the connection that pharmacists had with patients, and also I was very engaged in chemistry and science when I was in school. I actually competed in the International Science Fair. Like, I loved chemistry. And so I didn't really want to do the doctor thing. I had doctors in the family. I knew that wasn't for me, but I found that pharmacy was perfect because it was the science, it was the chemistry. There's a lot of teaching in pharmacy, and I like to teach. So I kind of found it met a lot of my goals and things that I wanted to do. And then as far as specialty areas go, I've known that I wanted to do pediatrics for quite a while. I always loved working with kids. At one point, that was why I wanted to be a teacher. I liked work with kids. But when I was in school, I actually really liked psychiatry. I didn't like it when I did my classes. I was like, these meds are crazy. There are so many side effects. I don't want to deal with them. But I did a psychiatric rotation and I really, really enjoyed it. So that was an area I kind of considered, and I actually did some psych work when I was in residency, just so I could kind of look at that from a pediatric lens. I also really like neurology and neuro, which is what you're going to see in this case today is kind of more on the neuro side of things. So there's other things that I've considered and really liked, but I have found that I can do most of those within the pediatrics women's health realm, so I kind of stuck with that.
Mm-hmm. Another question was, how has COVID affected your specialties, and what type of meds do specific units need now because of COVID?
That is an excellent question. So as a resident, it completely changed my residency experience because I was supposed to do an ambulatory care rotation, and then we didn't have any patients coming into clinic anymore all of a sudden. So our clinics were trying to learn things. So I actually was on the investigational drug service rotation right after COVID hit and got to be a part of the emergency authorization of remdesivir and acquiring remdesivir for patients whenever they needed it. So actually, we were working really closely with our physician team. The investigational drug service department, including myself, wrote the treatment plan. We did all of the paperwork to get that FDA approved. So the doctor was focusing on treating our patients. We were focused on getting the drug for them. And we've continued to do that. So remdesivir is a big thing that we need now. Actually, last week was when it was authorized for our younger patients. So prior to that, it was like 12 years of age. Now our patients less than 40 kilos were authorized for that. So that's a big one. Albuterol is another medication that we had to deal with a little bit of worry with shortage, not so much anymore. And then propofol was another medication. That one's used for sedation. That albuterol is used for helping breathing. And then the remdesivir is the first drug approved to treat COVID-19. And we've seen a lot of success with that. As far as pediatric patients go, there's not as many cases in pediatric patients, but when they are, we're seeing a very different presentation than we're seeing with our adults. So our pediatric patients aren't having as many of the breathing issues. That still does happen, but we're actually seeing this multi-inflammatory system response. And so these patients are having heart issues. We're seeing just massive inflammation in these patients. So we're also using a lot of drugs kind of investigationally that treat inflammation instead. So we are seeing some dexamethasone, which is a steroid that can help with inflammation. We're also seeing some other medications that are study drugs that we're trying to use. I can't think of their names right now because I haven't used them in a while. Thankfully, we haven't had any patients that have been that sick, but we are really not seeing as much as adults, but when we are seeing it in my situation, they're usually in our ICU. As far as our women's health side of things, most of the patients that I'm encountering with COVID-19 in our women's health population are asymptomatic. We test all of our moms before they give birth to make sure that they are not COVID-19 positive. We have a separate unit for those moms. That way that they're separate from our other moms that are negative. So most of them are asymptomatic. We do occasionally have asymptomatic patient that comes in. And usually what we see is they may need oxygen requirements during delivery, whereas most of our patients don't need oxygen requirements whenever they're delivering. So that's the biggest difference we see. I have not given remdesivir to a COVID-19 positive mom yet. There's not really good data or testing on that. I have seen that some people have decided to go ahead and do trials for that, but we have not at my site.
Wow, that's kind of crazy, like how big of a shift it is
Mm-hmm.
and the types of medicines you have to deal with. And there's just one more big question that we can do before we hop into the case study. Someone asked, the field, as you have mentioned, is getting oversaturated due to up-and-coming schools. Do you believe that it is still worth following this route based on the job outlook?
So this is a question I get very frequently. And I think it comes down to, if you love the profession of pharmacy, it is worth it. I do believe that you have to work a lot harder now to get the job that you want in pharmacy than you used to. And that is because of the saturation of the market. I was very nervous doing only 1 year of residency, but I did find a great job for me. It's absolutely perfect. It's where I wanted to be. So it's still possible. So what I like to tell people is, if you're going into pharmacy because of the money, because you think that it is good for your lifestyle, which it can and can't be just depending on what job you get, then that's not the good reasons to go into pharmacy. If you're going in because you want to work hard and you want to take care of a specific type of patient, and you really want to be a pharmacist because that's what you love, it's still worth it. You do have to realize going into it that going to classes in pharmacy school and just going to classes is likely not going to get you the job that you want anymore. Very rarely will that happen. Usually you have to work while you're in school. I worked at a women's hospital, actually the hospital I'm working as a pharmacist now, which I think is one of the reasons I got the job. I was an intern there for 3.5 years. So I worked during pharmacy school. That's pretty much an expectation now. When you're applying for jobs, that you've been a pharmacy intern somewhere, at least for a little period of time in school. And also expectations for being involved in organization and leadership or research, or both. Residency also can make a big difference. So knowing that going in, that you should be thinking, I'm going to do a residency. So even if you don't and you find a job that you want, you are setting yourself up for that, which does mean doing extra research, which does mean spending some extra time doing organizational work. I was in leadership, very involved with the American Pharmacist Association, Academy of Student Pharmacists, on the regional level, and I actually served on a committee at the national level. So there was a lot of involvement that I had outside of work and outside of just my classwork that got me to where I am today. It was worth all of that extra work, though, to be in the job that I love. So what I've been saying is, you're going to have to work harder than you did before, but it's still possible and it's still worth it. I know that there's jobs out there, they do go faster, but those people in my class that put in the extra time and put in the extra effort, they tended to get jobs and got them quicker than the individuals in my class that maybe didn't work or didn't do those activities. So it's really, knowing going into pharmacy that you're going to have to set yourself up for success, whether success, instead of success being handed to you like it used to be. Mm-hmm. Just being realistic about that.
Right. That's just, yeah, I feel like the more people that also get interested, it's just going to become even more competitive over time. So
I would agree with that.
Yeah. So did you want to hop into the case study?
Perfect. So for the case today, I do want to make it clear that I am a pharmacist, so I'm not trained to diagnose. So I'm going to kind of go briefly over the diagnostic part of it, just because that's not where I'm really involved. And I wanted to focus in on this treatment because that's where the pharmacist came in. And that's what we're trained to do, is really take whatever diagnosis our wonderful physician team members, NPs, NPAs get, and then work from there on helping find the best medication treatment for that diagnosis. So our case today is JW. He is a 3-month-old male. He is presenting to his pediatrician's office for his 3-month checkup. He was born in Texas, which actually will become very important later on. He was born via spontaneous vaginal delivery at 38 weeks, 2 days. So he was born at full term with no complications. But today his mother is coming in and she's pretty concerned due to recent changes in his ability to latch during breastfeeding and decreased muscle tone. So for his history of present illness and the review of symptoms that was done, basically they found out that he has had some difficulty latching since he was 8 weeks old. The mother went ahead and visited a lactation specialist and they had some success. It was getting a little bit better, but mom noted that there were more difficulties in this past week and she just was getting more concerned that maybe what the lactation specialist helped her with is not working anymore. And the patient had low tone in their arms, legs, and neck upon review of symptoms as well. And the mom noted that she hasn't really seen much improvement in their tone in the last month of life. As far as family history, the mom and father of the infant weren't really able to provide us much information about their past, but the mother knows that she did have a younger sibling who died as an infant, but that was, of course, before she was born, and she didn't really know what the cause of death was or if they even knew what the reason for death was. Upon physical exam, they noted, and getting vital signs, they noticed that oxygen saturations were on the lower end of normal, but still within the normal range. They had a moderate tone deficit in all 4 extremities and the neck. They were unresponsive to reflexes in the limbs. And when they did their growth chart, they were ranking in the 5th percentile, which partly was expected due to the issues with latching, and they think that there was feeding difficulties there. Other than that, everything was within normal limits. So basically, we came down to the differential diagnosis of the following disorders: congenital muscular dystrophy, congenital neuropathy, MG, SMA, carbohydrate metabolism disorders, and juvenile ALS. Most of these didn't really reflect the latching symptom, but some of them could, and having these other issues can cause difficulty with feeding. It may not actually be a latching issue, but other issues. So those were all things that we were considering when going into diagnostics. So the diagnostic test, again, I'm a pharmacist, so I wasn't super involved in this, but these are the ones that they really looked at closely. So they did genetic blood tests to test for diseases that were not covered in the Texas newborn screening, which is very important. So some states cover more diseases than others. So for anything that wasn't covered in that newborn screening, we did genetic testing for that. Electromyography was also done to test for the electrical activity of the muscles. And then a creatinine kinase test can also be done to just rule out some of those issues. We actually didn't get to that because the genetic testing revealed our diagnosis. So the diagnosis that this patient received was SMA Type 1, so spinal muscular atrophy type 1. And now I'm just going to kind of go into what spinal muscular atrophy is and what kind of treatment options we have for it. So spinal muscular atrophy is actually the #1 cause of genetic infant death. It is an autosomal recessive order that affects 1 in 10,000 births. We have roughly 1 in 50 people in the United States are actually carriers, so that makes out to roughly 6 million Americans. It's a neuromuscular disorder, and the big thing that we see is profound muscle weakness. So that hypotonia that our patient had is one of the hallmark symptoms of spinal muscular atrophy and what they often present with first. In severe cases, these patients can actually see hypotonia prior to birth, and they can actually note lack of movement in utero if the patient has a severe enough type. These patients also will have difficulty breathing over time, especially as that muscle weakness progresses. Actually, time to tracheotomy and time to ventilation is a hallmark measurement of disease progression. And then we also see feeding issues. So they have sucking and swallowing difficulties, which is what we were seeing in this patient. Lack of reflex is, again, something this patient presented with. And then once they start growing, we see inability for them to walk. Some of them won't sit. Some of them won't even be able to roll over or lift their head. So just very large range of abilities based on how severe the disease state is. So spinal muscular atrophy screenings are only done in 32 states. You can see here the ones in purple have screenings and the ones in gray do not. So 32% of all newborns are actually not screened for SMA, and Texas was one of those. So that's also important to note. In states that don't have this screening, we see more of the later detection, whereas we could have caught it at the newborn age, which we'll get into why that is so very important once we start talking about what our treatment options are and how that really affects their progress over time.
Just real quick, why would states not have testing as an option in the first place?
That's a great question. Every state determines on their own what they're going to include in the newborn screening. A lot of it has to do with cost. I'm just going to be honest. More and more states are getting the SMA screening. Texas now has it in trials. Some of it is just advocacy for this and pediatricians wanting more knowledge of this. SMA is one of those disease states that was not well known. And we've just seen an increase over time in identifying that. We had patients that were dying at young ages and we couldn't figure out why. Now we know it was SMA. So it's also very likely, like that mother was talking about the infant sibling that passed away, that they didn't actually know that it was SMA when they passed away. At the time, it was an unknown cause. So SMA particularly is a newer disease state in the grand scheme of things. So it's one of the ones that wasn't included in the original newborn screenings. So that's why it's kind of been added on later on. So we're seeing more and more of that, especially the spinal muscular atrophy associations have been pushing for it. And we've seen a big increase since they've been advocating for it and putting dollars behind getting these states to approve it. But that's a great question. So we'll move on from screenings and kind of go into the pathophysiology of SMA. So hopefully when we get to the drugs, they'll make a little bit more sense. So what I'm going to show you first is what a patient who doesn't have SMA looks like. So from a genetic perspective, SMN1 gene is the most important when it comes to creating SMN protein. This is survival of motor neuron gene. And this plays a very important role in the creation of that SMN protein, which is necessary for muscle function. So we have one copy of SMN1 and two copies of SMN2 in a non-SMA patient. So our SMN1 gene is responsible for most of our SMN protein production. It produces all this protein, which is really important for motor neuron cells to continue to live. Without SMN protein, these cells will atrophy and die, and you'll get these symptoms that we see of these patients having hypotonia, difficulty breathing, and inability to sit or walk. So this is our big thing that we need and what our SMA patients are lacking. So you're like, okay, we have SMN1 gene, but what about these SMN2 genes? Well, they still produce some SMN protein, but not nearly as much, roughly 10% of what our SMN1 gene produces. So as you can see here, if you don't have that SMN1 gene, you're going to have significantly less SMN protein. And while you have some, what really happens with SMN2 is it produces some protein, but it's not functional in most parts. So it produces short proteins, broken proteins. We're not exactly sure why that it's not fully functional in these patients, but it's not. So we see this protein's just not as effective in SMN2 gene. So patients who don't have SMN1 but have SMN2 will still produce some SMN protein, but it's not enough to have fully functional muscles. And as the patient grows older, you'll start getting neuronal cell death, which is very unfortunate. So let's look at the SMA patient. So I've kind of alluded to this already, But in our SMA patients, we're going to see no functioning SMN1 gene at all. And then this is really due to a mutation on chromosome 5, and these patients will see no function in SMN1, but we'll have some SMN2. And everybody, even if you don't have SMA, have different amounts of SMN2 gene. And so the more SMN2 gene you have, the more SMN protein you're producing, and the better your outcomes are. So these patients who have 8 copies, because that's the max that we've seen in a lot of our spinal muscular atrophy patients, they're going to do better than our patients who only have 1 or 2 copies of SMN2 gene, because they're going to have less SMN protein produced. So we see a wide range of disease progression based on the amount of SMN2 gene these patients have. I know this is a little complicated, so I was trying to make it basic. I hope you guys understand. If you have any questions, you guys can stop me. So basically, like I said, we have those different amounts of protein, and that breaks us down into different SMA classifications. So SMA 0 is the most severe. It's actually diagnosed before birth, all the way down to SMA Type 4, which some of these patients can be greater than 30 years of age when they're actually diagnosed with SMA, because they don't have as much deficit of protein. So until they get older, they don't really see the side effects of it. Or maybe they had minor motor impairment. And honestly, sometimes these people, they're like, oh, they're clumsy. Or, oh, they just don't walk very well. It's this or that. And they get misdiagnosed very frequently. But they typically have a normal lifespan. But what I want to focus in on is our patients with SMA type 1, because unfortunately, this is our most common type of SMA, and also the most severe after birth. So SMA type 1 is brought to our attention usually at 2 weeks, 3 months, or 6 months of life. So our patient was the 3-month range. And they really don't have any motor milestones prior to our drug treatments, because these patients have severe hypotonia. They often won't be able to sit or roll or, like I said, lift their head on their own. And the prognosis is very poor. So death or ventilation, which is 24-hour ventilation by the age of 2 years. So, that is extremely poor prognosis. And so that is why all of our treatment options have really focused on how can we help these patients, because if we're able to even slow the disease progression, they might meet some of those milestones, which has been the goal of a lot of the treatment for years, because what our treatment has been prior to drugs was respiratory support. So we would do ventilation, we will give them devices to help them cough. We would give them drugs to try to reduce the thickness of their mucus so they could cough it up easier. A lot of them had asthma, and then eventually would have to get a trach. We also would do a lot of preventative therapy. So RSV is a respiratory virus that everybody gets. It's, the common cold is RSV a lot of times. In most patients, they recover very easily. They don't get admitted to the hospital, but these patients, it could be deadly. So there is a drug. It's not necessarily a vaccine. Some people like to call it a vaccine, but palivizumab is a monoclonal antibody that we can give that reduces the risk of infection. It's very, very costly. So it's usually reserved for high-risk patients such as SMA patients. And these patients, we also make sure that we are getting their routine vaccinations on time. Other things with SMA treatment was most of these patients have other organs involved. It's a muscular disorder, but a lot of things are muscles. So they frequently had congenital heart defects. They had issues with their pancreas and often will have diabetes. And then they're at high rates of osteoporosis. So we were giving them drug treatments, insulin, surgery for their congenital heart defect, vitamin D and calcium for their osteoporosis, and really just things to kind of put a Band-Aid over their symptoms, but not really treating the SMA. But Christmas came early in 2016 for these patients. So on December 23rd, nusinersen or Spinraza was approved. And this is a complicated drug, so I'm not going to go into all the specifics of how it works. If you're interested, I have them on the screen. But basically, it's taking that broken part of their DNA and trying to make that SMN2 gene work better. So they don't have SMN1. We're just going to fix that SMN2 so it works a little bit better, and we can make those full-length proteins that are functional, which sounds great, right? But it's a little bit more complicated than just that because it's not a one-time thing. So it is approved for all ages and types of SMA, but it's an intrathecal administration of 12 milligrams per dose. So this means you're actually having to insert it pretty much directly into your spinal cord. It's not something that you want to do frequently, but unfortunately, it has to be done several times. So you do multiple doses, and every single dose is going to cost you $125,000, which will go into more costs later. And again, this isn't curative, but what it does help with is quality of life. So any damage that has already been done, so if those neuronal cells have died, they are dead and we can't bring them back. So whatever damage has already been done to the cells once they start a new synersin, we can't fix. But going forward, we're going to see less progression of disease. And it's not curative by any means, and it's pretty invasive with having to do intrathecal administrations multiple times a year. So we have two phases for this drug. So we have what we consider our induction phase, where they're going to get 3 doses every 14 days, and then a dose 30 days after the 3rd dose. And then after that, you're going to go into maintenance, where you're getting it every 4 months. So you're going to have to do 3 doses of this intrathecal administration every year for the rest of their life. This is indefinite, and if doses are stopped or missed, you will see disease progression. So this is a great option because before we didn't have anything. So, anything is better than nothing, but it's not ideal, and it's definitely not a cure.
So real quick, would insurance cover a drug as expensive as this? And someone also asked, what makes medications like these so expensive?
So I'm actually gonna go back to this to answer the expensive parts of why it makes it so expensive. But insurance typically covers things to a degree. Depends on the insurance company, always requires prior authorization. A lot of these companies also have patient assistance programs that we can get more of the cost covered, but it really depends. The problem comes in when patients don't have insurance and a child has this, and that's where we get more of the patient assistance side of things. We have social work get involved. So sometimes it's covered because what we like to think about is we can justify that this is going to reduce costs for the insurance company. So you pay for this drug, you're going to reduce their rates of admission to the hospital. You're going to not have to pay for trach care as soon. You're not going to have to pay for physical therapy sessions as frequently. These patients still do need physical therapy, but maybe not as many sessions or as extensive sessions. So we frequently can get this covered. But as far as why this is so expensive, and we haven't even got to the most expensive one, this is nothing compared to what I'm getting ready to show you, is how complicated it is to create a drug like this. So you're actually alternating the mRNA of the patient to get a gene that wasn't functioning very well to function. And so it takes extensive research, and we're going to the gene level to fix this. So the amount of research that has to go into that and the depth of the research that has to go into this is very extensive. And the other thing is the studies for these patients often take a longer period of time because there's not as many of them. So this is what we call orphan drug status, where it's for a rare disease that affects a small number of patients. The government does give assistance for these and does give fast track for these. So we do have programs now where these drugs get approved quicker, but you still have that time period where you're having to get just enough patients to prove that this works. And so these are tied up for a long period of time in just the research and development phase. So that's really where the cost comes in. It's a little different for the other drug we're going to talk about, but that's kind of the basics. But now let's talk about the really expensive one and the one that this patient actually got. So This nusinersen was the only treatment until 2019. So in May 24th of 2019, the FDA approved omnasimnogene abiparvovec XIOI, which I spent like 30 minutes learning how to say, also known as Zolgensma, which is what I'm going to call it for the next little bit. But this is actually really, really cool. So this is an adeno-associated vector-based therapy. So basically we take a virus, we take all the virus components out of it, and we put the missing SMN1 gene inside the virus and give it to the patient. So the patient now has this fake virus shell with the SMN1 gene inside. So it's inside this virus vector, and it will work like the regular SMN1 gene to increase the amount of SMN protein in the body. So going back to that pathophysiology of SMA, so we have this broken SMN1 gene that doesn't work. Now with Zolgensma, we are basically replacing that broken gene with SMN gene type 1 that replicates inside the body and creates the fully functional SMN protein, which is awesome. The only downside is, just like nusinersen, it cannot reverse the damage due to dead motor neuron cells. So really what's important is starting treatment early. If you can get ahead of it, if you have minimal hypotonia, we can give this shortly after birth, and we can prevent that hypotonia from ever happening. So it can be very impactful.
So is there any way to find SMA while the baby is still in the womb? And if so, could it be injected while the baby's still in the womb?
That's a great question. So that's part of the research they're doing now. So you can diagnose a patient with SMA prior. You can get testing from the parents to see if they are carriers of SMA. So that way we know, if both parents are a carrier, we're at higher risk. They can do genetic testing prior to birth. If they're getting that newborn screening, we're finding out very quickly. So that's usually where we find it, right away. The other thing is with giving it prior to birth, that's not actually been studied fully yet. One of the things they're looking at is, can we give this to the mom? If we know ahead of time that this baby has SMA, can we give Zolgensma to the mother, and will the baby get the effect of it? Does it cross the placenta? Will we see that effect? They're also looking at, can we inject it, in utero and see if that works. They've not done that yet. More so because the dosing becomes a little bit tricky with that. And that's the same thing with mom. We don't know how much do we give mom in order for it to be enough to affect baby. And we'll also talk about the cost of this drug and why that's a little bit difficult. But those are areas of research and questions that have been brought up about this drug once they found out how effective it was. So for these patients, it's actually approved for patients that are less than 2 years of age. Again, the reason for that is because the disease usually has progressed to the point that they're not going to get enough benefit from giving the drug if they're older than 2. And it's only for patients with SMA Type 1, which is the biallelic mutations of SMN1 gene. So these patients also need to be full term, or at least to their full term gestational age before we administer it. So if they're born preterm, we need to wait. But the great thing about it is it's a single IV infusion. So one and done, we're not going to give another infusion. And the biggest thing is we haven't seen any safety and efficacy data on repeat administration. They're also learning, does this ever wear off? So we're only about 5 to 6 years out of the patients who were first admitted to the studies. So we don't know past 5 or 6 years how these patients will respond. But this is really impactful because basically before these patients were on a drug indefinitely, and now it's possible that they could be getting one infusion when they are right after birth and then they're done. So it's a pretty interesting drug. So I did want to bring up this side note. We will be going with Zolgensma. That is what this patient received. But at the time of the case, there was only 2 options. And we recently had approval of another drug for this disease state, and it's the first oral agent to treat SMA. And it actually enhances Similar to nusinersen, it's not the same mechanism of action, but very similar, where it's enhancing that SMN2 protein production. And it's approved for 2 months or older in SMA type 1, 2, or 3. And the cool thing that they're doing is they're actually studying patients who have been previously treated with SMA, with nusinersen, with Zolgensma, to see if they can further improve these patients' functionality. So it's actually being used more as an adjunctive treatment than kind of like alone, because we do have 2 agents that we know work well and have been able to, help these patients have a better quality of life. So I'm going to now go through the whole process to giving Zolgensma, omnisimnogene abiparvovec XIOI. And then we're going to go through, the price will be in this area, and we'll talk about how we chose to do this and all the things that go into getting this patient the drug and what happens afterwards. Because while it's a one-time infusion, there's a lot more that goes into that for these patients. So first, we're going to talk about lab testing and the diagnosis confirmation. So this is super important. And before we can even talk about getting the drug on board, we have to confirm that through genetic testing, the exact type of SMA that they have, what kind of gene mutations do they have, and make sure it fits the criteria for this drug. We also obtain a dosing weight. So these patients are babies, and we have to make sure that we have a weight that we're going to use for them, because this is a weight-based dose. And then we also check their anti-AAV9 antibody titers. So basically, this is the virus shell that we put the gene in. And so we want to make sure that their body does not have too many antibodies against that virus, because if they do, then the baby's body might actually break down the drug, and then it's not effective. So if their titers are too high, then we can't give them the drug. And then we also want to look at their baseline liver function tests, platelet counts, and troponin 1, because these are all things that were found in the studies to be affected by the drug. So we want to know where they are at baseline. That just because maybe their levels are high of 1 or low of 1 doesn't necessarily mean we won't give them the drug, but we need to know where they are so we know what is a change for them. Is it, 2 or 3 times what we were before? Has it dropped significantly, or are we still at their baseline? So then we want to talk about pre-infusion storage and handling, because this is very important on the pharmacy side. So it will arrive frozen. You have to sign for this drug. It is handed only to specific individuals. The drug company will make a list of people who are allowed to touch this drug. I'll talk about why in a second. So it arrives frozen. You want to put it in the refrigerator, and once it's in the refrigerator, it must be used within 14 days or you cannot use it. And it breaks down very easily, so it cannot be shaken. So you don't want to drop the box. And all of this is very important because one dose is $2.1 million, making it the most expensive drug in the world. It's crazy.
That's
it's
insane.
Crazy. Yeah, it is insane. I saw your face. It is crazy, and there's a lot of reasons for it. It is one of only 2 gene therapies that we have where we're actually taking a gene that is broken and replacing it through a virus vector. We've only done that with one other gene. There's a lot of disease states that are looking at it, but this is one of the first ones that's done that. So there's a lot of research and development that went into creating a whole new way that we treat genetic disorders. There's also some other things which I'll talk about later that comes with this drug, but they're getting 1 dose. So that's the other reason they haven't tried to redose it yet, because it's $2.1 million for 1 dose. So the question that I got, go ahead.
I was saying, so this is kind of like setting the precedent for other gene therapies, and that's probably why it's in the millions.
It is, and that's the biggest thing. They are one of the few that have actually been successful in doing this. So they have tried to do this, and this has been a theory for a while that we can do this. We can use viruses or vectors to get drugs in there to stimulate the body to react to that and duplicate it and replace missing genes, essentially. but this is one of the few cases where they've actually been able to do it. The other reason it's so expensive is probably due to the success. So I didn't want to go into the studies because that gets a little overwhelming, but basically we have patients who are with SMA type 1 who, like I said previously, would either have death or permanent ventilation by the age of 2. Nobody broke that stereotype without drug treatment. We have seen patients who took Zolgensma who are able to walk on their own. They are 5, 6 years old now. They're still able to walk, talk, sit up. I mean, every patient in the study was meeting milestones that had never been met before for patients with SMA. So this drug has truly changed lives, continued lives that would not be there anymore. I mean, it's very, very, very good drug. So if it wasn't that successful, it probably wouldn't be able to be justified at that price tag either. But what I wanted to bring up was the cost comparison with nusinersen and what you have to get into with insurance companies, because that's the difficult part. Is, okay, we have nusinersen, which seems a lot cheaper. Why should we pay $2.1 million to cover omnisimagene abiparvovec? Well, the reason is, if you actually add up all the costs, so your induction phase, your maintenance year 1, and then your maintenance each year after that, approximately 17 doses of nusinersen from direct cost alone is 1 dose of Zolgensma. So that's less than 5 years of nusinersen treatment. So if these patients on nusinersen would live to the age of 5, you are already saving money because they have only gotten 1 drug. The other thing is all the indirect costs. So we don't have a head-to-head comparison of Zolgensma and nusinersen, but we have seen a lot of the Zolgensma patients meet milestones that nusinersen patients hadn't at the time. So it's possible that we're also reducing cost for inpatient admissions and things of that nature because these patients are doing better and not getting to those stages where they're going to have to be admitted very frequently. So those are all considerations when we're working on prior authorizations to get this drug covered. So next is pre-medication, which is not nearly as exciting, but basically they get a prednisolone equivalent of 1 mg per kg per day, 24 hours prior. We also bring them in at that time to reweigh them and then report the changes to the 1 gene program. And this is another reason the cost is so high, is the 1 gene program. So this is the program that the drug company has available to families, and it has basically all in one for everything the patient will need and the team that will be providing for them. So they have patient resource managers, which provide emotional support, answer questions for families, connects them with other families who have patients who are on this drug. They have a field reimbursement manager, which really works with us to try to get the drug reimbursed or as much coverage as possible, or programs that provide money to get this drug covered. We also have, they're the ones who help us with shipping as well, and the pharmacy team, and they're the ones who bring the drug to us. They don't just send this FedEx. They have somebody who is with that drug at all times and hands it off. So, you know, that's a big part of it. And then they have case coordinators that actually work with the doctors and provide information on insurance and financial assistance. And they'll actually send somebody out to stay with us if we, you know, as the administrator, want somebody else there. The family and the provider team can actually request somebody come for infusion day and answer any questions that we have. So the 1 gene program adds the additional cost as well, because you have all of these individuals that are working towards 1 dose for 1 patient.
Mm-hmm.
So then next is infusion day. And infusion day, I'm not going to go into all the details, but basically each of the patient's kits come with a certain number of vials, which is the dose. And we have that, you know, previously decided whenever they ship it to us. And once we draw it up, we have 8 hours to get it to the patient and deliver it through infusion. So on infusion day, we really rely on our awesome nursing team to get everything lined up and set up. They do recommend having a backup line, so an arm and a lot. Sometimes they'll do both arms, sometimes they'll have one in the arm and the leg. We recommend having that backup line in case one of the IVs goes bad, we want to make sure we get it in. They just prime the line, administer it over 60 minutes, and then flush the line, and the patient's done. They've got Zolgensma. And then they go into post-medication and monitoring. So similarly, they have to take that prednisolone 1 mg per kg per day equivalent on the day of treatment, and they continue that after that. And then we draw their liver enzymes, because that's the biggest reason we do the prednisolone, is to try to keep the inflammation down and prevent the adverse effects of issues with the liver, which is the big adverse effect. So that's why we give the prednisolone. And then based on what their liver enzymes are, we will taper them off of that over time. And this is where, again, pharmacists really help, especially the pharmacists who work for the One Gene program are very involved in this. And then we have the follow-up monitoring, and I took this table directly out of the package insert information, but we'll continue doing liver function tests, platelet counts, because we do see drops in platelets, and then troponin 1, which is a cardiac marker. We haven't seen any true cardiac issues from this, but we have seen increases in levels, so we have continued to monitor that just to be on the safe side. Important to note, it does have a boxed warning. So for those who aren't familiar with that, those are the most severe warning we can get for a drug, but it does have a boxed warning for severe liver injury. So that is the primary thing that we are concerned about during this therapy and why we do the corticosteroids.
So considering how common this disease is, would you say that Zolgensma is something that is administered on a daily basis across the United States, considering its price value, or is this something that is like a rare drug administration process?
So I would say it's pretty rare. Even though SMA type 1 is the most prevalent type, we still don't have that many patients with SMA overall.
Mm-hmm.
So we had only administered it one time since it came out at my previous institution, which was a very large institution and had a world-renowned neuro team. So we're not going to just be doing this in any hospital. They're going to go to specialists to get this, and we don't see it very often. So there's very few patients who are going to qualify and meet the genetic markers that they need to in order to get this drug. And you also have to think these are only the patients who are less than 2 years of age that have SMA type 1. So we aren't seeing tons of patients getting this medication at the time. We're seeing more patients on drugs like nusinersen, which is approved for everybody who has SMA. And I'm sure that that oral agent is going to be used very frequently as well, probably on top of these two agents. Since it's just approved in August, I haven't seen it yet. And probably the biggest reason is, approval happens, but then it takes months and months for you to actually get access to the drug. So I don't know that access is available to it yet for the oral agent, but we aren't seeing as much of Zolgensma.
Okay.
And a lot of patients are trying to enroll in studies still because it is covered. So if they're having trouble with insurance coverage, they're actually waiting to try to get enrolled in a study instead to try to get coverage for it.
Right.
And speaking of studies, I just wanted to throw this up here to show you how many things are going on. There's actually more studies now than there are on this table, but these are the ones that are most up and coming. So they are trying to do a lot more with this drug than just SMA type 1 patients. So they're expanding it out to SMA patients with type 1, 2, and 3 now. They're also looking at patients that have more copies of the SMN2 gene to see if, we can make even further progress with them. We're actually increasing the age for some of these. So there's a lot of things going on, as well as long-term follow-up studies, which will be very interesting to see. Does the efficacy of this drug wane over time, or does it stay consistent? Do those patients not have any more disease progression? How long does that last? Those are all questions we have. And in addition to what we are seeing with Zolgensma, we're also seeing a lot of other disease states that we are trying to cover. So ALS is a big one that they are really pushing for drug therapies that do something similar to Zolgensma to see if we can stop progression. So if we get an early diagnosis, can we stop somebody from progressing to ALS that causes death? Those are the things that they are really looking at with this gene therapy administration, and it could really change genetic therapy overall. If we can start finding ways to give these missing genes to patients and that can be replicated in the body, we can potentially stop those genetic diseases becoming devastating to patients. So it's a really cool type of drug, and one that they're thinking is the future of genetic therapy.
Mm-hmm.
So that's all I have.
That was mind-blowing. Like, that was truly one of the best case studies I've ever seen. But there was a question someone asked, and they said, being a healthcare provider, what's your take on America's pharmaceutical industry with expensive drug prices and sometimes inaccessible services / access?
So I have lots of feelings about it. As a pharmacist, I do get frustrated because I see therapies out there that are very beneficial to patients, and we can't get easy access to them. So one of the real bummers with this drug is we know the quicker we get it on, the quicker or the less disease progression we see. Unfortunately, we get tied up in prior authorizations, and sometimes it can take months to get approval for drugs like this. Same thing with nusinersen. We're tied up in getting authorization from the drug company to cover it. So those parts of it are frustrating. I do understand from their perspective why drugs are so expensive. I mean, what they are doing is groundbreaking research that has never been done before.
Mm-hmm.
And that cost a lot of money up front that they have to recoup. So I can see both sides from, knowing how much any research costs, even if it's more basic research. I can only imagine the price tag on the research and development that went into this drug. And also knowing how few patients at the beginning of their FDA approval actually qualified for it. So for me, I really appreciate the researchers and the scientists that work for these companies and what they develop, because this drug wouldn't have been developed without the money that backs big pharma. I mean, that's just
Right.
That's just a fact.
Mm-hmm.
I hate that we don't have good access for those patients once they are developed. And that is the frustrating part on our end. The other thing that's very frustrating is we have pharma drugs that are very expensive like this, but what actually is affecting our day-to-day patients, not these patients with specialty drugs or rare disorders, but your average American who has diabetes, heart disease, that sort of thing, is not actually big pharma. It is pharmacy benefit managers. And I did a YouTube video on them recently because it's actually going to court right now. The Supreme Court is actually hearing this case and will hopefully have a verdict in June. But this was actually the in-between person between big pharma and the insurance companies, and they do a lot of negotiating of prices. And what it first was, a couple insurance companies would get together, they would, have one PBM. This pharmacy benefit manager would negotiate with the pharmacy company. It was actually saving patients and insurance companies money. Over time, they started adding more fees and incorporating more costs to the pharmacy, and that was then getting passed to the patient and the insurance companies. And so now they actually jack up a lot of our prices. And pharmacies have no control over the pricing. And so what we're seeing now is the pharmacy benefit managers are actually increasing the cost more than our drug companies are in a lot of cases. So that's very unfortunate. And there's no regulation of pharmacy benefit managers because they're technically not insurance and they're technically not a pharma company. They're this in-between person. And so the regulation of this organization is being tried right now in the Supreme Court. They just heard the opening case statements in October. So we'll be seeing possibly changes in drug pricing from that perspective. I would say it's very frustrating as a pharmacist to not be able to get drugs for the patients because of cost. I have to say that it is very frustrating, or seeing delays in care because of it.
Right. And I completely agree. It must be like really hard to be in your shoes to because then you get both, you understand both sides of it with the pharma and the, yeah, but I don't see like what you could change about it, like in your shoes. So
No, really all we can do is advocate for the patient, and that's what I do, as much as possible. A lot of times they don't want to talk to the pharmacist, they want to talk to the physician, but we work as a team. So anytime we're going for an investigational drug product, or if we are trying to get patient access to something like this that's on the market, it's really, okay, here's the doctor, I want to give this drug, help us make a case. And so the pharmacist will go, and we do a lot of the behind the scenes work, paperwork, pulling articles that we know of, and work with the physician to make a really strong case for the insurance company on why this patient needs this drug and why they qualify. And oftentimes we try to tell them how it's going to save them money in the long run.
Yeah. Well, thank you so much for talking about all of this with us, the pressing issues and this enormous price tag on a medicine. I didn't even know medicine could be that expensive.
It wasn't until this one came out.
Yeah. But again, we really appreciate it. So there were a few questions that were unanswered. However, we are over the time limit. So you guys can check out her Instagram at Happy Farm Life. I'll type it in the chat. So if you guys have any questions, you guys can DM her, and she will get back to you whenever she is free or is available. And you guys can also email her happyfarmlife@gmail.com. So the @ I just put with @gmail.com at the end. And make sure you guys tune in next week for Dr. Knock, who is a PhD immunologist. And he is also working on vaccinations for COVID. So that's also another interesting topic you guys might find fascinating. Well, thank you again so much, Sierra. And I will see all of you guys next week. Bye.